Good evening. Welcome to another session of Zooming Through ID. I'm Dr. Gopal, an infectious disease specialist who has been practicing in South Florida for over 20 years. I trained at Duke University. I am here at Broward Health North. I'm the medical director, and I chair the antibiotic stewardship for the four Broward hospital system. Zooming Through ID is a program that I have designed. It is like a focused learning session where the residents and fellows take ownership of learning. Each presenter will select a topic, either of their interest, or we will assign them a topic, and they do research in that topic and they showcase what they have learned. These sessions are not just learning the facts, but um, they have to be more like intellectually curious and think about what is the take home, why is this topic relevant in clinical practice, and you have to be critically thinking about these topics. So today the topic is very interesting topic, malaria, and Michelle is going to present the topic. Michelle rounded with me, and she was excellent. She was very thorough in her presentation, and she's genuinely interested in seeing all the variety of cases, and so she's going to talk to you all today. I will let Michelle take over.
Mm. Hi, everyone. My name is Dr. Michelle Sindoni. I'm a PGY1 at Broward Health North in internal medicine. I'm interested in doing primary care outpatient when I'm done with residency, but it was a pleasure to get to learn more about infectious disease while I was rotating with Dr. Gopal. All right. Today, my presentation is about malaria, so I hope you enjoy it and learn some things you didn't know before and can take away some things you can bring into your clinical practice. All right. Oops.
Perfect.
Okay, so this is Malaria by me. This is our fun little mascot for the presentation. His name is Marvin the mosquito.
I love it. I love it.
Yeah, so
Very
today I'll be talking about malaria, which is a disease we often associate with global health, but one that's increasingly relevant in the US hospitals as well. I'll focus on high-yield concepts for clinical care and boards, and we'll end with some board-style questions and a case report. Okay, so this is an overview of malaria. Malaria remains one of the most deadly infectious diseases worldwide, with hundreds of millions of cases each year. Nearly half the global population lives in areas where malaria is endemic. What's important for us as US clinicians is that malaria is not just a travel disease, that we've seen it locally acquired as well. So recognizing it truly saves lives. This is an overview why malaria matters. It's preventable. It's a mosquito-borne parasitic infection. There's over 263 million cases worldwide, and of those cases, 597,000 deaths as of 2023. Nearly half of the global population is at risk of malaria. It's becoming increasingly relevant in non-endemic countries, such as here in the US. Um, it's increasingly drug resistant, and something important to note is that any patient that comes in with fever and a recent travel history, you first have to think of and rule out malaria until proven otherwise. Malaria significantly impairs economic growth, tourism, healthcare spending, and productivity in endemic regions. Households in high burden countries may spend a large portion of annual income on prevention and treatment. Some people get prophylactic medication, which I'll discuss later, before they travel, and that is a cost to us as travelers. Epidemiology. So there are many different causative species of malaria, all beginning with the species Plasmodium and then have different ones from that. So Plasmodium falciparum is the most common and most severe disease. It causes a lot of microvascular sequestration and the most deaths. Next, we have Plasmodium vivax. It has less mortality than falciparum, but it has huge relapse burden. And we have Plasmodium ovale and malariae, which are less common, and Plasmodium noalesii, which behaves like falciparum, but it is mainly in the Southeast Asia region. We have a figure here showing a worldwide map. It shows the global distribution of malaria separated by species. In the top panel, you see Plasmodium falciparum is concentrated in sub-Saharan Africa, which explains why this region carries the overwhelming burden of malaria deaths worldwide. Falciparum is also the species most associated with severe disease, like I mentioned before. In contrast, the bottom panel shows Plasmodium vivax, which has a much broader geographic distribution, particularly across South America and Asia. Although vivax is often less lethal, it causes significant morbidity due to relapse from dormant liver hypnozoites. Clinically, this matters because where a patient traveled predicts which species you're treating, how severe disease may be, and whether relapse preventing therapy is required. Next, we have the pathophysiology. So I have this beautiful figure here, which demonstrates the life cycle of Plasmodium and where we intervene. So infection begins when an Anopheles mosquito injects sporozoites into the bloodstream during a blood meal. These sporozoites quickly travel to the liver where they infect hepatocytes. And this phase is clinically silent and lasts about 1 to 2 weeks. In Plasmodium vivax and ovale, some parasites become dormant hypnozoites, which can reactivate months to years later and cause relapse. Merozoites are then released into the bloodstream and infect red blood cells, which is when the clinical symptoms occur, such as fevers, anemia, and thrombocytopenia. Plasmodium falciparum is unique in that it can sequester in the microvasculature and placenta, leading to severe disease. Some parasites differentiate into gametocytes, which are taken up by another mosquito and continue the transmission, causing endemic and pandemic disease. All right. This is just another more simpler version of the mosquito transmission cycle. You have the first infected person, which infects liver cells, infects red blood cells, which another second mosquito feeds off of and infects another person, and the cycle goes on and on. Okay. This is the clinical presentation for malaria. Malaria often presents very non-specifically with fever, chills, headache, body aches, nausea, vomiting, and cough, which is why it's frequently misdiagnosed. Some lab clues that should raise suspicion include anemia and thrombocytopenia, which help distinguish malaria from viral infections, as well as elevated liver enzymes and creatinine and splenomegaly in chronic cases. Severe disease is more likely in children, pregnant patients, and non-immune travelers. Now, how do we diagnose malaria? The gold standard for diagnosis remains thick and thin blood smears. Thick smears are more sensitive, while thin smears help identify species and quantify parasitemia. This allows you to identify species and quantify the percentage of parasitemia. A key teaching point is that a single negative smear does not rule out malaria. Smears should be repeated every 12 to 24 hours, up to 3 times if suspicion remains high. Other tests include rapid diagnostic tests like HRP2 antigen or PCR. Here I have an image with the different species in the different stages on histology. So they look very similar, but you can easily distinguish them from each other. Okay, diagnostic pitfalls. There are some limitations to diagnosing malaria. Rapid diagnostic tests are commonly used, especially in resource-limited settings, but they have limitations. Many rely on detection of HRP2 and genetic deletions in Plasmodium falciparum, which can lead to false negatives, which is a problem in Africa. RDTs can't quantify parasitemia and remain positive even after treatment. But PCR can confirm species, but it's not used for acute decision making. And serology is only used for past exposure. Now, how do we treat malaria? So we have mild, uncomplicated, and severe forms of the infection. So for mild, uncomplicated malaria, artemisinin-based combination therapy is the cornerstone of treatment. Artemether-lumefantrine is most widely used regimen worldwide. Alternatives include atovaquone, proguanil, or quinine-based regimens when ACTs are unavailable. Combination therapy prevents resistance, and chloroquine is only used in limited regions. If you're uncertain of what species you're dealing with, then you just treat it like it's Plasmodium falciparum since it's the most common species. For severe malaria, the treatment is slightly different. This table outlines the criteria for severe malaria, and the most important takeaway from this table is that only one criterion is needed to make the diagnosis of severe malaria. You don't need multiple findings. Severe malaria is a medical emergency, most commonly caused by Plasmodium falciparum. Regardless of the species, IV artesunate is the treatment of choice and should be started immediately. These patients often require ICU care for complications like cerebral malaria, kidney injury, seizures, shock, inability to ambulate, or severe anemia. Any delay in treatment can dramatically increase mortality. From a lab perspective, high parasitemia, over 10%, in non-immune travelers is a major red flag. Hypoglycemia, acidosis, kidney injury, pulmonary edema, and severe anemia all independently qualify as severe disease. The keynote of this slide is that do not wait for patients to look critically ill. If they meet any single criteria, you treat it as severe malaria and escalate care immediately. Don't delay treatment waiting on tests, and supportive care such as IV fluids, glucose monitoring, and renal function monitoring matters a lot. A big thing, like I mentioned before, with malaria is relapse is a problem, especially with Plasmodium vivax and ovale. So we need to prevent the relapse. Because the blood stage treatments alone are incomplete treatments. So primaquine and tefenoquine is required to eradicate hypnozoites, but both can cause hemolysis in patients with G6PD deficiency. So a quantitative G6PD level must be checked before prescribing these medications. Tefenoquine is a single dose, but there are strict criteria to give the medication, and pregnancy is a contraindication to this medication. Now, as with treating any medical condition, complications are possible. They range from severe malaria and seizures to acute kidney injury and respiratory failure in malaria. There are also treatment-related complications such as delayed hemolysis from the IV artesunate that's given for severe malaria, which can occur weeks later, as well as hemolysis in patients with G6PD deficiency. Now, I mentioned that in pregnant patients, things are a little bit different. So I have a whole slide dedicated to that. Pregnancy significantly increases the risk of malaria because of altered immunity and unique parasite behavior. Plasmodium falciparum can adhere to placental tissue, which can lead to placental malaria, which disrupts oxygen and nutrient delivery to the fetus. Clinically, pregnant patients are at a higher risk for severe malaria, hypoglycemia, kidney injury, and death, while fetal complications include low birth weight, prematurity, miscarriage, and stillbirth. First-time pregnancies are particularly high risk. Now, from a treatment standpoint, severe malaria in pregnancy is treated with IV artesunate, regardless of what trimester the mother is in. For uncomplicated malaria, ACTs are generally preferred, but primaquine and tafenoquine are contraindicated because of the risk of fetal hemolysis. Prevention is critical. Insecticide-treated bed nets and intermittent preventative treatment in pregnancy are key strategies in endemic regions, and avoiding travel to these regions, if possible, while pregnant is also recommended. This is a slide on prevention. Prevention relies on multiple strategies such as mosquito control, chemoprophylaxis, and now we have vaccines. So the vaccines that we now have, the RTSS and R21 vaccines, provide partial protection in children in endemic areas. For travelers, prophylaxis selection depends on resistance patterns and patient factors. Non-adherence is the most common cause of imported malaria from one country to another. And so counseling on, this process matters just as much as prescribing. Now, the RTSS, also known as Mosquirix, is the first WHO endorsed malaria vaccine for Plasmodium falciparum. It reduces severe disease and hospitalization in young children. The R21, also known as Matrix M, is another promising vaccine with high efficacy in trials. Vaccines are being integrated into childhood immunization programs in endemic countries and represent a new era of malaria prevention. I will explain specific travel prophylaxis on the next slide. So this is a table describing the prophylaxis. So you will start these medications before travel, take during exposure, and continue on return from your travel. The choice of medication depends on the region you're going to and resistance in those areas, as well as patient factors and dosing preference, because they are different days in duration. Prophylaxis decreases risk, but it does not eliminate malaria. So as clinicians, we should evaluate any post-travel fever. So this table displays the common medication options, such as atovaquone proguanil, which is a daily medication that you stop 7 days after return. And it's pretty well tolerated. However, you need to avoid it in pregnancy and severe renal disease. The other medication is doxycycline, which is also a daily medication, but you continue it 30 days after return. And some side effects include photosensitivity, esophagitis, as well as needing to avoid in pregnancy and in children under 8 years old. Permaquine and tenofovir are best for Plasmodium vivax regions, but it does require a normal G6PD level before prescribing. And tenofovir is weekly dosed after a loading dose. Chloroquine is weekly dosed as well, and it's safe in pregnancy, but you would only use it in chloroquine sensitive regions. And then lastly, mefloquine. It's also weekly dosed. It's also pregnancy safe, but it can have some neuropsychiatric side effects, so avoid in patients that have a known psych history. This is just, another FYI slide for prevention of malaria. Try to wear long sleeve clothing, protect your skin, use mosquito nets to prevent mosquitoes from directly contacting you while you're sleeping, and use mosquito repellent when you're going out and about. Now, fun fact about malaria, there's some human genetic resistance. Some people are superhumans and have resistance to malaria. It's Malaria has exerted one of the strongest evolutionary pressures on the human genome, leading to the selection of genetic traits that provide partial protection against infection or severe disease. The most well-known example is sickle cell trait, but not sickle cell disease, which significantly reduces the risk of severe Plasmodium falciparum malaria. Other hemoglobinopathies like alpha and beta thalassemia also impair parasite survival within red blood cells. G6PD deficiency offers some protection against malaria, but is clinically important because it predisposes patients to hemolysis when treated with drugs like primaquine or tafenoquine, which is why you need to test for G6PD levels before giving these medications. And finally, the Duffy antigen negativity, which is common in many populations with African ancestry, provides resistance to Plasmodium vivax by preventing parasite entry into red blood cells. So that was just a rundown of malaria, and now we're going to kind of make sense of it and make sure that you were paying attention and test your knowledge a little bit. First, I have a case study that I want to go over to just show you an example of what a patient might present with who ends up having malaria. So we have a 28-year-old woman who presents to the ED with 7 days of intermittent fevers with a Tmax of 103 Fahrenheit, chills, rigors, severe myalgias, headache, and nausea. She reports symptoms come in waves, worse at night. Over the last 24 hours, she has developed dark urine and mild shortness of breath with exertion. No cough, dysuria, rash, neck stiffness, focal neurological symptoms, or sick contacts. Some travel/exposure history. She returned 12 days ago from Indonesia in the Papua New region after a 3-week backpacking trip with rural stays, frequent evening outdoor exposure. She used mosquito repellent inconsistently and slept without bed nets for several nights. She did not take malaria prophylaxis due to cost and concern about side effects. She has no past medical history, doesn't take any medications, doesn't have any allergies, and denies any tobacco, alcohol, or drug use. Her vital signs, temperature is 102.9 Fahrenheit, heart rate 118 beats per minute, blood pressure 96 over 58, respiratory rate 20, and oxygen saturation 99% on room air. She's ill-appearing, diaphoretic, has mild scleral icterus, dry mucous membranes. Neck is supple with no meningismus. She's tachycardic, regular rhythm without murmurs. Lungs are clear to auscultation bilaterally. She has mild left upper quadrant tenderness with palpable splenomegaly. She's alert and oriented without focal deficits and has no rash or eschar. Labs significant for CBC with hemoglobin 10.1, platelets 62,000, white blood cell 4.8. CMP shows bilirubin 3.4, AST 76, ALT 64, creatinine 1.4, and glucose of 68. Hemolysis markers, LDH is elevated, haptoglobin is low, and UA is heme positive with few RBCs. Lactate is 2.4. Imaging, chest x-ray shows no infiltrate, and right upper quadrant ultrasound shows no biliary obstruction. Now here is where the good information comes. The diagnostic testing, rapid malaria antigen test is positive, and thick and thin blood smears. Plasmodium vivax was identified with enlarged RBCs with amoeboid trophozoites and stippling parasitemia of 1.2%. So this case demonstrates a typical patient who has uncomplicated Plasmodium vivax malaria with hemolysis, anemia, and thrombocytopenia. So in this case, you would start oral ACT or chloroquine, depending if local sensitivity is known or confirmed. And you would start with supportive care, which includes IV fluids, monitoring glucose, and monitoring renal function. The plan for radical cure includes primaquine for 14 days or tafenoquine, single dose if patient is eligible after quantitative G6PD testing. And then you have to counsel on relapse prevention, mosquito avoidance, travel prophylaxis for future trips as well. And to test your knowledge, we have some board review questions. First question, we have a 42-year-old man who is evaluated for a 3-week history of daily fevers, chills, headaches, fatigue, and malaise. He reports no nausea, vomiting, abdominal pain, cough, or dyspnea. He is a healthcare worker and returned to the United States 2 months ago from a trip to Pakistan, where he provided medical care in rural clinics. Before leaving Pakistan, he developed similar symptoms. At that time, he was evaluated and prescribed empiric malaria treatment with artemether, lumefantrine for 3 days, leading to symptom resolution in 4 days. Results of laboratory testing were pending at the time of departure to the United States. On physical exam, temperature is 101.7 Fahrenheit, blood pressure is 110/70, and pulse rate is 110. Respiration rate is normal. Mild scleral icterus is noted. Abdominal exam reveals hepatosplenomegaly. No rash is present. Laboratory studies, hemoglobin is 8, platelets 90,000, ALT 75, AST 86, and total bilirubin 3.1. Which of the following is the most likely cause of this patient's illness? The answer is Plasmodium vivax. Oops. Oh, I guess this is the wrong. Okay. I will explain the answer. All right. So this patient received treatment for erythrocytic symptomatic stage of malarial infection, but he did not receive additional treatment to eradicate the liver hypnozoites that can cause relapse. Option A was incorrect because it is a mosquito-borne virus that predominantly presents with severe myalgia and arthralgia. Although thrombocytopenia and elevated aminotransferase levels also occur in chikungunya, severe disease is uncommon, and illness typically resolves spontaneously in 7 to 10 days. In addition, anemia is not a major feature of chikungunya. Option B, dengue, is incorrect because it is a mosquito-borne hemorrhagic virus. Patients may present with fever, frontal headache, retroorbital pain, and myalgia. As the fever abates, a sclerotiniform rash, which spares the palm and soles, may evolve into areas of petechiae on extensor surfaces. A few patients may develop organ dysfunction and shock. In most cases, dengue fever resolves within 1 week. This patient has been ill for several weeks with no evidence of hemorrhage or hemodynamic instability and no appearance of a rash. His clinical course is not compatible with dengue fever. And lastly, salmonella is also incorrect. That causes enteric or typhoid fever. Patients have high fever, chills, abdominal pain, nausea, and vomiting. Occasionally will have a rash with blanching, salmon-colored macules. This patient has hemolytic anemia, which is not a typical presentation for typhoid fever. And this patient also doesn't have any GI symptoms. Next question. A 51-year-old male is evaluated for fever, headache, and anemia. He recently returned from an extended tour of the Amazon River. This is an image of his peripheral smear. What is the most likely diagnosis? So this answer is malaria. This peripheral smear shows erythrocytes that are infected with Plasmodium vivax, like I showed you in the slide before for diagnosis. The trophozoite for Plasmodium vivax is amoeboid shaped, and the enlarged infected erythrocyte contains numerous Schnupfner dots. Okay, question number 3. A 34-year-old woman presents to the emergency department with a 2-week history of fever, chills, and a headache. She notes that the symptoms worsen every day or two and then subside. She recently returned from a trip to Ethiopia. Vital signs reveal temperature 103.8 Fahrenheit, blood pressure 101/65, heart rate 112, respiratory rate 20, oxygen saturation 99% on room air. Physical exam reveals mild scleral icterus and peripheral jaundice. A peripheral blood examination is notable for intraerythrocytic organisms. Which genus contains the species that transmitted the responsible organism? And the answer is Anopheles, which I mentioned early on. Malaria is an intraerythrocytic parasite transmitted by the Anopheles mosquito that causes systemic illness, periodic fever, and jaundice due to erythrocyte hemolysis. A rapid antigen test can be used to confirm the diagnosis. Now, answer A, Aedes, is incorrect because that is responsible for transmitting yellow fever and dengue fever. Answer B, Ambyloma, is incorrect because that is a tick species genus, which includes the Lone Star tick, which is a vector for auriculosis. Answer D, Culex, is incorrect because it is a genus of mosquito that is a vector for various encephalitis-causing viruses, such as Eastern equine encephalitis virus, Western equine encephalitis virus, and West Nile virus. And answer E, Ixoides, is also incorrect because it is a genus of tick species in which deer tick is the most important, and it's responsible for carrying Borrelia, Lyme disease, Anaplasma, and Babesia. And my last question, question number 4. A 16-year-old Ugandan girl is brought to the emergency department with a 3-day history of fever, headache, cough, and myalgia. She has had several episodes of malaria in the past. On admission, she is febrile, tachycardic, tachypnic, and has oxygen saturations of 90% in air. A thick, thin smear shows 6% erythrocytes infected with Plasmodium falciparum, and a chest radiograph shows left-sided pneumonia. What is the most appropriate management for this patient? The answer is intravenous artesunate. This patient has severe Plasmodium falciparum malaria. The treatment, according to CDC guidelines, in patients with severe malaria should be treated with IV artesunate as soon as possible, regardless of the parasite density. Answer A, oral atovaquone proguanil, is incorrect because it is an oral medication, and that is not what you should be giving for severe malaria or with high parasitemia over 5%. And this patient has 6%. Due to the risk of rapid progression to coma or death. Answer B, oral chloroquine, is incorrect for the same reason as answer A. Answer D, oral primaquine, is incorrect because it is used for radical cure of dormant liver stages of Plasmodium vivax and ovale to prevent relapse. It is not for treating acute Plasmodium falciparum. And answer E, immediate exchange transfusion, is incorrect because it is usually reserved for extremely high parasitemia, over 10%, and this patient only has 6%, or if the patient fails to respond to anti-malarial drugs. Now, in summary, the biggest takeaway is that malaria is treatable, but only if we think of it early. ACT is the backbone of therapy. IV artesunate saves lives in severe disease, and prevention remains key both globally and for travelers. Here are my references, and here is a slide of mosquitoes. Thank you for your attention.
Okay. Great job. I think you covered everything, and it's interesting that we do have two vaccines now, and that is used for less than 5 years old children in sub-Saharan Africa. So we have developed a lot for in that direction. So that is amazing. Your presentation was very thorough. You touched upon everything, the chemoprophylaxis, how important it is in pregnant females, and then all the treatment guidelines of malaria. So excellent job.
Thank you. Hopefully everyone learned a little bit about
And
malaria.
yeah, definitely. And we are in the Fort Lauderdale area, and we do see a lot of travelers. So I'm sure you will see malaria cases while doing, your rotations. We always get one or two malaria cases in, all the time.
Yes, absolutely.
Okay, wonderful.
Thank you.
Bye.